So hello everyone and welcome to the case 13 of this case discussion series, and today we'll be discussing a very interesting case. So we have a 50-year-old male who has a history of pulmonary TB 2 years back, and he took and finished the course of ATT. Now he came with severe headache and seizures since past 1 week, and this is the axial section MRI brain T2 weighted images of that patient, where we can see that there is one lesion which is T2 hypointense to isointense in the thalamus, which is compressing the third ventricle. Also, there is one lesion in the left frontal region and in midbrain. Similar lesions are present with extensive perilesional edema causing obstructive hydrocephalus and dilatation of bilateral lateral ventricles. This is the T1 weighted images axial section, where we can see that lesion is again isointense to the gray matter. This is the post-contrast T1 weighted images, where we can see this frontal lesion as well as the lesion in the thalamus and the brainstem, which is peripherally enhancing. This is the DWI images, where there is no restriction, there is no high signal on DWI, which is seen. There is extensive edema, which can be seen on FLAIR. And now this is the GRE images, where we don't see any foci of blooming. So this is the report that was given. That's a well-defined thick-walled ring-enhancing lesion in the left thalamus with extensive edema associated with considerable mass effect, especially on the third ventricle, causing its effacement and upstream dilatation of bilateral lateral ventricles with transependymal periventricular edema. The lesion appears isointense on T1 and iso2 hypointense on T2 and does not show any restriction on DWI or blooming on GRE sequence. On MRS, it showed lipid lactate peak. MRS was also done. And similar small ring enhancing lesions were also seen in the left midbrain and left high frontal region. There was no abnormal meningeal enhancement or any evident basal exudates which were observed. So I uh, gave the possibility of an active caseating tubercular granuloma more than a tubercular abscess. Now, intracranial tuberculosis has many manifestations. They can be extraaxial and they can be intraaxial. Extraaxial manifestations of intracranial tuberculosis include a tubercular meningitis, which is most common, and tubercular pachymeningitis, which is relatively rare. The intraaxial manifestations include tuberculoma, focal tubercular cerebritis, intracranial tubercular abscess, tubercular rhomencephalitis, and tubercular encephalopathy. The complications of CNS tuberculosis include hydrocephalus, which was present in this particular case, and it was of non-communicating type, that is obstructive hydrocephalus, because the granuloma was compressing the third ventricle and hence causing upstream hydrocephalus. Then there can be ventriculitis, choroid plexitis, and arterial vasculitis causing infarct. So what exactly are intracranial tuberculomas and what are the various MR imaging features that are seen? So intracranial tuberculomas are usually secondary to an infective focus elsewhere, usually pulmonary, and they are more commonly seen in pediatric age group than adults. And they can occur anywhere in the cerebral hemisphere, in the basal ganglia, in the brainstem, and the cerebellar hemispheres, but they usually are located in the corticomedullary junction or the periventricular white matter, owing to the hematogenous route of dissemination. They can be small or large in size, and they can be solitary or multifocal in nature. On MRI, they vary according to the type. The main three types of intracranial tuberculomas include non-caseating intracranial tuberculoma, caseating with a solid center, and caseating with central liquefaction. Non-caseating granulomas are hypointense on T1 and hyperintense on T2 weighted images and show a post-contrast homogeneous enhancement. Caseating granulomas with a solid center appear hypointense on T1 and they are markedly hypointense on T2, as was in this particular case, and they are highly cellular, and that accounts for their hypointensity. Granulomas with central liquefaction show a peripheral hypointense serum as compared to a non-caseating granuloma on T2 weighted images. And this low signal is because of the capsule which has collagen content. There can be extensive edema and mass effect which is seen around the granuloma, especially in the early stages of its formation, and the rim enhancement on post-contrast images is typically seen. So this is what is very important. So an important DD is tubercular abscess, and how do we differentiate it from tubercular abscess? So tubercular abscess is very important thing that we have to remember about tubercular abscess. It is less than 10% patients with CNS TB who have tubercular abscess as a presentation. Secondly, the elderly and the immunocompromised patients are usually prone to developing tubercular abscess compared to a normal patient suffering from tuberculosis. On imaging, tubercular abscesses are usually very large in size, more than 3 centimeter, multiloculated, conglomerated, T2 hyperintense. This is very important, an important feature to differentiate from granuloma, that abscesses will be T2 hyperintense. As is the case in pyogenic abscess, tubercular abscess will also be T2 hyperintense. It will be multiloculated, more than 3 centimeter, with enhancing wall and extensive mass effect and peripheral edema. It is usually solitary, again important point to differentiate from granuloma, and diffusion weighted imaging showing restricted diffusion because of the pus. Then important feature to differentiate tubercular abscess from pyogenic abscess is on MRS the tubercular abscess will give lipid lactate peak and it will show a lower magnetization ratio as compared to a pyogenic abscess because of the lipid.